Hello, everyone. Today we're going to talk about overcoming the challenges of teaching quality improvements to residents. I'm Nate Scott.
And I'm Glenn Paetow.
We have no financial relationships to disclose. After our talk today, we're hoping that learners will be able to anticipate commonly encountered barriers in quality improvement education, implement strategies to overcome these barriers, and while doing that, utilize best practices in quality improvement education. Between the two of us, we have several years of experience, both as a residency program director and as associate program directors. And as part of that, we've mentored dozens of residents and students in quality improvement projects in different formats. Also, one of us has a formal administrative role in quality and safety at the institutional level, providing a different perspective on this topic. So the ACGME has put forth requirements that residents be involved in quality improvement projects and also have formal quality improvement education. And they followed up on this requirement as part of the Clinical Learning Environmental Review. These requirements are core program requirements, and likely part of the reason you're watching this today is you're trying to figure out how best to meet these requirements in a way that both meets the requirement but also results in effective educational as well as project experience for your residents. In spite of this being a program requirement for some time, we still have a ways to go in terms of improving the education around quality improvement as demonstrated in the CLARE findings report in 2018. In addition to this being a required educational activity, most of us recognize that as teaching institutions, residents are our frontline staff, and that clinical care and quality improvement will be improved if our residents are engaged as part of that process, if not leading it in some circumstances.
So in general, we have a few different ways that we're teaching quality improvement to trainees. There's the formal curriculum with didactic components, quality improvement in the clinical context, and then non-clinical or quality improvement projects that are happening in conjunction to the clinical work. In the formal curricula, we tend to teach definitions in quality improvement in healthcare, talk about process improvement mechanisms, including lean, talk about aim statements, plan, do, study, act cycles, fishbone diagrams, and root cause analyses, discuss patient safety, vulnerabilities, and safety systems implemented at the hospital, such as event reporting mechanisms, discuss philosophies such as the culture of safety and just culture, engage them with teamwork and leadership exercises, as well as the basics of change management. These are typically done in didactic settings or in small group sessions with the residents. Now, in the clinical context, we have a little bit more experiential learning, where on shift, residents might discuss errors or near misses that have happened while working, utilize the event reporting system, hear from attendings on the importance of adherence to protocols that keep patients safe, or discuss the importance of different handoff mechanisms that lead to patient safety. Residents participate in multidisciplinary rounds, and we emphasize the utility of these for providing patient safety and identification of quality improvement best practices. The third and final way of teaching quality improvement is allowing residents to develop and engage with quality improvement projects. Now, quality improvement projects has multiple steps, including the identification of a problem, objectively measuring that problem, deploying some kind of intervention or change, and then measuring afterwards in order to figure out whether or not that intervention was helpful or ended up not being as helpful as expected. And finally, the last part would be to sustain or spread that change, helping people to change their behavior or spreading this to different areas of the hospital. Now, many of our projects start with the identification of a problem that frustrates us and the desire to employ some kind of change, to intervene upon that and to do something. One recent example is that our residents wanted to increase the frequency and the quality of education while on shift, and the decision was made to go ahead with an intervention, including whiteboards in the emergency department. Now, these whiteboards worked for a short amount of time, but unfortunately, the change didn't last. This is an example of a project, something that was frustrating for a group, that they went straight to an intervention without the quality improvement process behind it. The importance between a project and a quality improvement project is the process here. The focus on outcomes and not necessarily the interventions. The focus on some kind of objective measurement of those problems and the assessment of those outcomes. Now, these interventions are deployed to improve the problem, and their effectiveness needs to be assessed after the fact. Multiple interventions over time are typically employed in order to improve those problems, and we use the process of improvement science in order to generate a quality improvement project. So now we understand the basics of a quality improvement project, but this takes time, guidance, and coaching. Now, there are many barriers to teaching quality improvement, and first of all is time. Our residents are very busy taking care of patients and learning, and so getting them to help out with a quality improvement project on their free time can sometimes be challenging. Likewise, for the faculty, the investment of time into curriculum development, teaching, coaching, and mentoring becomes a barrier that we frequently run into. Project management software or skills are also a barrier that we find and difficult to overcome when there's not a centralized system for residents to engage with. Obtaining data in a meaningful way can sometimes be a challenge, whether that relates to the fact that we haven't been collecting this data previously in the electronic health record, or getting this data involves arduous labor of chart reviews or checklists. Obtaining stakeholder support is of utmost importance in sustaining change after a quality improvement project, but obtaining that support can be a barrier, especially when a quality improvement project affects multiple different groups in different ways. Now, prioritizing the electronic health record work can also be a challenge. Prioritizing these individual quality improvement projects and getting them to the head of a long list of projects can sometimes be a challenge. Recently, with the pandemic, allowing residents to come together in order to work collaboratively on a project has also become a challenge. And finally, we recognize that many faculty are limited in their experience with quality improvement processes.
All right, great. You know, with those barriers, of which there are several, there are specific strategies that are available that we've used in our experience to help overcome them and more commonly have our projects result in a successful project. The first of these strategies is group projects. So as opposed to having each resident individually come with the quality improvement project, which is something that we've tried in our program, we found that group projects are a more effective way to address some of these barriers. With group projects, it really helps account for the lack of an individual's time, as there's more people to spread the work between, oftentimes which will have availability at different times, and also really helps effectively leverage the faculty expertise that you do have in the department, rather than having your medical director mentor dozens of individual projects, much more manageable to manage one or two at a time. Second strategy here is to choose problems that can be measured. Now, we all know there are important things in medicine that can't be measured well, but in terms of finding a quality improvement project for a group of residents to do on a short, with a limited amount of time, finding things that can be objectively measured is going to be an easier way to get them started. One of the things that this helps address is just that process of getting data. Having things that are easily measured are simply speaking, you're going to be able to get data much easier. Another strategy related to data is to use data that already exists. Most likely, your emergency department or institution is sitting on reams of data that could be used for a potential quality improvement project, but aren't. We recommend going to your medical director, nurse manager, or whoever it might be in your institution who a lot of data flows through, and talking to them about what type of data they have that's already present. This is an example of a project where we looked at how many of our patients being seen in the emergency department were getting referrals out to a food assistance program. Now, a lot of our residents had a desire to do a project helping to address the social determinants of health. We didn't know that this data was available until one of our faculty happened to connect the dots. But this allowed an interest of the residents to be met with data that was already being collected, but really wasn't being acted upon with any type of improvement goals. Aligning with system priorities is another effective strategy for addressing a number of barriers. When there's alignment between a quality improvement project and institutional goals, you're likely already to have a significant amount of stakeholder support for this project, which helps a number of things advance. One of those primary things is getting appropriate prioritization of any electronic health record work that needs to be done. Simply speaking, a number of different project and improvement strategies do involve modifying the electronic health record in some manner, and this helps ensure that your project is towards the front of the line.
Now, it's vital to choose and develop effective mentors as we begin to teach quality improvement to residents. We understand that many of our faculty have limited experience with quality improvement. However, incorporating faculty that are engaged with the quality improvement process at higher levels, at the departmental level, or even at the hospital level, can be very effective. Personally, as a junior faculty, I didn't have much experience with quality improvement in medical school or in residency. I was engaged with the quality improvement curriculum to help develop it from an educational perspective, and over the years, being mentored by people who are more familiar with quality improvement, I've become more comfortable with the terminology and the processes of teaching quality improvement. Now I've incorporated it with some of my other interests in simulation, and this is an effective way of mentoring junior faculty to get them to be involved in the quality improvement process, allow them to help teach the quality improvement process, and make this an effective educational endeavor for your residents. This addresses mainly the barrier of the limited faculty expertise which needs to be developed over time. Another way of addressing these barriers is joining existing teams that already exist within hospital frameworks. Many hospitals have quality improvement offices that are already working on initiatives in order to improve the quality of care and patient safety. Allowing residents to join these teams so that the voice of frontline workers can be heard and be utilized to effectively carry out these quality improvement processes is vital. It allows the residents to access data that they might not have had previously. It allows them to work with groups that already have stakeholder support at the institutional level. It allows residents to engage with projects that are already at the front of electronic health record work so that it can be prioritized and done effectively. And finally, it allows residents to join a team that is already being managed or has access to project management software so that things can be carried out effectively. Now, another way to address these barriers is to provide that time and structure for the residents to learn quality improvement. It's vital to carve it out of the residency program educational time and provide structure for this curricula that includes didactics as well as experiential learning. And there's multiple examples in the literature that explain how to engage with this with both residents and faculty as they learn together about the quality improvement process. Finally, you can leverage technology, especially during this time of the pandemic, where residents aren't able to frequently come together and work on quality improvement projects. It's vital to have a centralized project management system so that residents can share data and work on a project longitudinally where not every resident has to be in the same room in order to be contributing. Now, this is not an endorsement of any specific technologies, but these are some examples of platforms that have HIPAA-compliant solutions to sharing data and allowing for video conferencing. This would be able to help support these teams going forward when they aren't able to come together in person, addressing these barriers of geography during the COVID-19 pandemic. So in summary, we've tried to go over many of the frequent barriers that we run into as we try to teach quality improvement to trainees, as well as some of the strategies that we've employed in order to overcome these barriers.
Now, there's lots of different ways that these strategies can be implemented, and obviously what makes sense at one institution won't necessarily make sense at another. So we've just presented an example, a summarized version of what our curriculum looks like for resident quality improvement education at Hennepin. So in our program, our first-year residents participate in the curriculum, which consists of two parts. The first is our formal curriculum. So we have 6 sessions annually carved out during conference time which each take about an hour each. And during those sessions, we do some kind of didactic and small group teaching around some of the core quality and patient safety topics, some of which we listed in the formal curriculum earlier, then also have time set aside to advance a longitudinal project that the PGY1 residents work on over the course of the year. Now, when we talk about what projects we're going to take on, we typically vet a couple different projects ahead of time, and we look at, do we already have data? Where do we already have data that we could use? What are the institutional priorities? And find something of appropriate scope that would make sense for a resident project. We work on the project during conference sessions, and then also throughout the year, each first-year resident has a week that's set aside to work specifically on quality and to advance this project. Then at the end of the year, we actually require that the residents submit their work to a local quality forum, which helps build some accountability into the process. We really thank you for listening today. There are all sorts of great resources to help to draw from. You don't just have to rely on us, naturally. There's the Institute for Healthcare Improvement Open School, which is a great foundation for a more didactic, self-paced learning curriculum. The AAMC Teach for Quality website has all sorts of different resources that are helpful. And then there's also assessment tools that you can build in as part of your curriculum. Thanks for your time. Please feel free to reach out to either of us with questions. We'd be happy to discuss further. Thank you.